Welcome, and thank you for joining us today to recognize National Recovery Month. My name is Michelle Gilbert, and I'm a Senior Policy Analyst with the Bipartisan Policy Center's Health Program. Addiction in the United States is not merely a statistic. It's a pressing concern that touches the lives of more than 1 in 10 adults and 1 in 4 young adults who grapple with a diagnosable substance use disorder. The reality is over 100,000 lives were lost due to drug overdose in the past year alone. The country faces a troubling situation as polysubstance use and the supply of fentanyl continues to rise. Xylazine in the fentanyl supply has unveiled new and dangerous threats for those who use drugs. Despite the gravity of the situation, treatment rates remain dishearteningly low, and recovery often necessitates multiple attempts. The road to healing is wrought with challenges, but it's a journey we cannot shy away from. Thankfully, there is a path forward. With the right structures in place, treatment and recovery can be a reality, not just a possibility. Thanks to action by both the White House and Congress, we're making progress. The Biden White House has committed to improving access to treatment and recovery services. Through the 2022 National Drug Control Strategy, which emphasized the creation of a recovery-ready nation, to the FDA's approval of an over-the-counter brand of naloxone, a life-saving medication, and efforts by the DEA, HHS, and the VA to safely maintain access to critical medications via telehealth, the administration has made great strides. Important progress has also been made in Congress. The X waiver, once a barrier for doctors, has been eliminated. The Bipartisan Safer Communities Act increased investments in certified community behavioral health clinics. These are just a couple of examples, but more must be done to address the nation's behavioral health and overdose crises. Lawmakers on both sides continue to seek bipartisan solutions to this problem. Earlier this month, Senators Kaine and Braun introduced the Peer Support Act, which aims to expand the peer recovery workforce. As we speak, Congress is working to reauthorize the Support for Patients and Communities Act. In 2018, this legislation transformed the federal approach to addiction care, addressing the overdose crisis with a comprehensive strategy. It directed federal resources towards prevention, education, treatment, and law enforcement programs, while also authorizing crucial grant programs that enhance access to recovery services, including recovery housing. Policymakers have an opportunity to eliminate the remaining obstacles for recovery. At BPC, the Health Program and the J. Ronald Terwilliger Center for Housing Policy are dedicated to crafting recommendations to enhance access to addiction treatment, recovery services, and tackle homelessness. You can find our policy proposals at bipartisanpolicy.org. Now I'd like to introduce Dr. Ken Schatzkes. Through his career, Ken has been dedicated to finding patient-focused, innovative solutions to combat the opioid crisis. He serves as a senior program officer at the Foundation for Opioid Response Efforts. Ken's background includes extensive biomedical research and innovative work on infectious diseases at NYU and the FDA, and as an advisor to the governor of New Jersey. I'll hand it over to you, Ken.
Thanks, Michelle. Hello, everyone. My name is Dr. Ken Schatzkes, and I'm the program director at the Foundation for Opioid Response Efforts, or FOR. For those of you that don't know us, FOR is a national grant-making foundation with a focus on supporting and accelerating solutions to the opioid and overdose crisis. We will actually be marking our first 5 years as a foundation next week in Washington, D.C., where we'll be bringing together a network of nearly 104 grantee projects being spearheaded by over 120 leaders across the country, working on all aspects of addressing the opioid and overdose crisis. Virtual registration details are on our website, and we hope you'll be able to join us. But as part of our grant making, we have a major focus on piloting innovative models and best practices to increase access to treatment and recovery services. Projects such as the one with the University of North Carolina Horizons program, a residential treatment program for women. Jenna's project, named for a previous patient who fatally overdosed shortly after being released from incarceration, focused on strengthening treatment and recovery supports for pregnant and postpartum women in a state women's prison by introducing them to the Horizons program prior to release, meeting them physically at the door upon release at any time of the day or night, and then connecting them with the support and treatment resources they need, including medical services, housing, and even daycare. Over 200 women completed this program over 2 years, and incredibly, there was not a single overdose that occurred. FOR also performs research that allows us to listen and learn from those with lived experience, such as peer recovery coaches. Peers play an indispensable role in helping people find treatment and sustain their recovery, but little is still known about the workforce itself. So we commissioned the most comprehensive survey to date of 1,200 peer recovery coaches working across 11 states to support people with opioid use disorder. And we learned what motivates them to do their work and what supports they would need to remain in the profession. I encourage you to go to our website and check out the results, but what you'll see is this is a workforce that wants to do this work. And with behavioral health workforce shortages all across the country, they are just looking for proper career support and fair compensation, just like we all want, to do the work they care about and help people recover. We also understand that these models and findings won't do us any good if the people who need these services can't access them. And that is where policymakers come in. The reality today is policymakers are currently drinking from a fire hose, navigating changes on multiple fronts in substance use policy after decades of it remaining largely unchanged, such as considering permanent adoption of COVID-19 federal flexibilities around methadone, changes in prescribing regulations, expansions in telehealth and harm reduction services, as well as considering increases in federal grants and Medicaid options. That is why we fund work such as our grants to the Bipartisan Policy Center and the National Academy for State Health Policy, who both are focused on helping both federal and state policymakers on both sides of the aisle identify best practices and policies that could help spread life-saving, evidence-based approaches to treatment and recovery. Now, I brought up Jenna's project before as an example because on many of the issues that we'll be talking about today, the science can direct us to what works to help people recover. So I want to end discussing a recent policy change related to Jenna's project that has the opportunity to save countless lives. Currently, the Medicaid inmate exclusion policy results in individuals losing their Medicaid coverage while incarcerated. And there are often delays in Medicaid enrollment upon release when individuals are at high risk of overdose. One study found North Carolina inmates were 40 times more likely to die of an overdose within 2 weeks of release than other state residents. Only an act of Congress can permanently change this policy. However, in January of this year, the Centers for Medicare and Medicaid Services approved California's 1115 waiver application to, for the very first time, demonstrate the use of federal Medicaid dollars to pay for certain healthcare services, including substance use disorder services, inside correctional facilities during the last 90 days of a person's incarceration. Our grantee Legal Action Center, who advocated tirelessly for this, has called this an absolute game changer in the way we will be able to deliver care and quickly connect people leaving incarceration to treatment and recovery services. And other states have already submitted waiver applications for the same. This bridge to treatment and recovery is something that could have saved someone like Jenna's life. It is my hope that when implemented, we can begin to fill these cracks, pave a clearer path for people to recover, and prevent overdose deaths, such as the one Jenna experienced, from happening to others. So I want to thank Bipartisan Policy Center for allowing me to join you all during National Recovery Month, and I look forward to what is expected to be some thought-provoking discussions today.
Thank you, Ken. Now it is my pleasure to introduce our panelists, Shelley Weitzman and Dr. Jeffrey Singer. Shelley Weitzman is the project director at the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown University. Shelley is a human rights lawyer with a passion for advancing public policy concerning addiction, mental health, and disabilities. She also serves on the board of directors for Faces and Voices of Recovery. Jeffrey Singer is a senior fellow at the Cato Institute's Department of Health Policy Studies. Jeff is the founder and president emeritus of Valley Surgical Clinics and is the oldest and largest group of private surgical practice in Arizona. He has spent over 35 years as a practicing general surgeon. Our guests will discuss addiction patient experiences and barriers to treatment and recovery services. If you are watching on YouTube, feel free to enter questions into the live chat. You can also submit questions on Twitter using the hashtag BPCLive. Let's dive in. Because some of our viewers may be new to this topic, can you please describe the differences between treatment and recovery? I'll start with you, Shelley.
Great. Thank you, Michelle. And so wonderful to be here this recovery month on a panel talking about recovery. So one thing that you didn't say in your intro, but I'll say is that I'm a person in long-term recovery. I began my recovery journey 25 years ago, and it's just wonderful to be able to be here speaking about policy solutions and programmatic solutions to this really challenging issue. And I think it's a great question to start with, because I think a lot of times people don't really understand what we mean when we talk about recovery, and how do we make this a concrete item that can be funded, developed, how there can be innovation around. I think people probably understand in general treatment, going to a residential program or receiving medications like methadone or buprenorphine for an opioid use disorder. But when we talk about recovery, we are talking about all the things that help people have some stability in their lives and maintain that stability and ultimately thrive. So we think about this, I think about this in categories of health, home, community, and purpose. So recovery services can include recovery community organizations, which provide a safe place for people to meet, to connect, to get support. It can mean peer support, which are services provided by trained professionals who've walked the same road as the clients that they're trying to help. For example, after an overdose in a hospital, or following incarceration, or even during incarceration. It can also include a wide range of other services and supports, like housing support, for example. That's a safe place maybe for a new mom in recovery to live with her baby, and that helps her transition to a long-term stable housing situation. Transportation to get to treatment, or even court if somebody is involved in the criminal legal system. Support with food security, employment support. So, all of those things that help us just to live life every day. And you don't have to be someone with a substance use disorder to need those things that need support. But that's what we're talking about when we mean recovery services and supports.
That's great. Jeff, I'm going to turn it over to you as well. And I know you have the clinical background to be able to talk about this from the patient perspective.
Yeah, sure. And thank you for having me on this panel. It's a very important discussion we're having. Well, just from a strictly, sort of disease model point of view, treatment is the intervention that the clinician initiates to stop to correct the problem, and recovery is the response to the intervention where they're getting over the problem. Addiction is, for those who don't know, is defined as compulsive use despite negative consequences. And when most people seek treatment, they've already had a lot of negative consequences in their lives. Sometimes it could be, living in the street and having a whole bunch of other health conditions as a result of their decisions, a result of their addiction, rather. So the benefit of treatment, and it's treatment that appears to be the most effective, as based on comparative effectiveness studies, is medication-assisted treatment with, for example, methadone or buprenorphine medications for opioid use disorder. And the way it helps towards recovery is because by eliminating the concern that you're going to go into withdrawal, which is a terrifying fear that people with substance use disorder have. These drugs not only prevent withdrawal, but they reduce craving. And all of a sudden, you now have a lot of time on your hands that you didn't have before. You don't have to spend your day trying to come up with the money to buy the drug on the black market. You don't have to figure out a way to meet that person without getting caught. So now you could get back to focusing on getting your life back together and reestablishing relationships, which is crucial to recovery as well. Connectedness is crucial. So as a clinician, the way I view treatment is in helping the person through medical interventions like medication-assisted treatment to get their life back stabilized and back in order, and then that's their road to recovery.
That's great. This is all really helpful. I know some of our listeners or viewers may not have the same background. And Shelley, I just wanted to thank you truly for sharing your experience. I know as a policy expert and as a lawyer, you have this great, robust background, but it's really great too that you have this personal experience. Now, switching gears a little bit to the policy barriers, would you both be able to describe some of the policy barriers to both treatment and recovery? And Jeff, I'll start with you.
Well, yeah, there are a lot of federal and state regulatory obstacles to people who want to help treat people with opioid and other substance use disorders. So, for example, just recently, happily, Congress lifted the X waiver. There were onerous requirements on clinicians, including primary care clinicians and nurse practitioners who are clinicians who wanted to be able to treat people with buprenorphine. A lot of those restrictions have now been lifted, including restrictions on what types of clinicians can treat patients with buprenorphine. But we still have very onerous and I would argue archaic restrictions on the way we treat people using methadone, which has been shown to be effective since the 1960s. So in Canada, the UK, and Australia, since the 1960s, you can go to your primary care clinician, and your primary care clinician working with a pharmacist can treat you just like any other person with a health problem. You're treated, you're not segregated out and stigmatized. When you're sitting in the waiting room, nobody has to know whether you're there for a blood pressure check or to talk to your clinician about your substance use disorder. But in this country, you have to go to a federally approved outpatient opioid treatment program, or OTP, and there are numerous restrictions on what the requirements they must meet, and then states put their own restrictions, including zoning restrictions, so that local communities with their not in my backyard attitudes don't want them in their area. And there are restrictions such as you have to go every single day and take it in front of staff because you're a quote unquote addict and can't be trusted. Somehow that's not the case if you're taking buprenorphine. So these barriers need to be lifted. We had a paper out 2 weeks ago at the Cato Institute where we argue that Congress should allow primary care clinicians to prescribe methadone to their patients in their clinic, as they now allow them to prescribe buprenorphine. But on top of that, even if they did all that, I think you can still see a slow uptake like we have with buprenorphine, because the Drug Enforcement Administration it has been conducting raids on doctors who are prescribing buprenorphine according to their X waiver requirements. And many of these doctors are losing their licenses to practice. And this is intimidating. So a lot of healthcare practitioners who might otherwise want to treat opioid use disorder with either buprenorphine or methadone are going to be afraid to. So there needs to be actions taken in that area as well to get law enforcement to stick to intervening where people are breaking the law, like, for example, selling prescriptions on the street or something like that. But if they think a doctor is prescribing not according to the standard of care, in my opinion, that's a standard of care question and should be referred to the state licensing board. It's not a police matter.
Yeah, that's a really good point. And you bring up this kind of shift from medications in a clinic to on the black market. And I know with fentanyl on the rise, this is a huge concern. So can you talk a little bit about how fentanyl has changed the game and what that means for patient care?
You talking me?
Mm-hmm.
Well, first of all, fentanyl is already starting to fade into the past, and we're now seeing fentanyl plus xylazine or tranq. And there's another class of synthetic opioids on the horizon called nitazines, which we're starting to see as well, which is even more powerful. First of all, the reason we're seeing this is because of what drug policy analysts refer to as the iron law of prohibition. The harder the enforcement, the harder the drug. It's an economic principle. It incentivizes the people who are dealing in the illegal substance to come up with more potent forms of that substance that are easier to smuggle in smaller sizes. And then when you successfully smuggle it, you can then subdivide it into more units because it's more potent and they get more bang for your buck. So that's why when diverted prescription pain pills were reduced, and the number of diverted prescription pain pills were reduced to, according to the DEA, close to less than 1% now are diverted. So the black market filled in first with heroin, and then we saw this rise in heroin deaths. But then about 2012, they discovered if you add a little bit of fentanyl, which could be synthesized in a lab like meth very easily, you add that into the heroin. Now the heroin's more potent. You can smuggle in smaller sizes. And then gradually that started to appear more and more mixed in with heroin. And until the pandemic really accelerated things because we had supply chain issues and we had border closures. And to make heroin, you got to, first of all, transport opium, and then you got to process it with acetic anhydride. And it just became much more easy to just make fentanyl in a lab like you make meth. So fentanyl pretty much replaced heroin. But then in the last couple of years, we've been seeing the veterinary tranquilizer xylazine get added to that. So the problem is getting worse and worse because we're continuing with the exact same approach, pretty much the same approach since the war on drugs started, which is incentivizing the production of ever more potent forms and more deadly forms of drugs.
Yeah, it almost seems as though when you solve one problem, another one pops up out of the woodwork. And that's really helpful. So Shelley, I'm going to turn it back to you. I know we've heard a lot just now about the kind of treatment related barriers. And you discussed a couple minutes back the impact of non-medical services on recovery. So just wanted to turn it back to you. What are some of the policy barriers around making these non-medical services and recovery services available and making them a reality for as many people as possible? I believe.
Yep.
Oh,
off
great.
mute.
Off
Still
mute.
3 years later, I'm doing it. I think piggybacking off of what Dr. Singer said, there are a lot of collateral consequences to the criminalization of drug use. So when you think about it, someone's at maybe the lowest part in their life, already, has experienced a lot of trauma, and as a way to deal with their substance use disorder, they go to jail or prison and experience more trauma. The trauma of incarceration, the difficulties following incarceration when someone has a felony or even a misdemeanor on their record to get a job, to get access to housing, loans, anything, school, licenses being suspended, driver's licenses, and licenses to work. So, really recognizing that to truly address this, we have to look at this in a much more holistic way and examine our policies and identify which ones are making it harder for someone to live their life, and what's not working, what's working, and what's frankly not working. What are some things that maybe we did 30 years ago that we don't need to do anymore? And identifying if there are, and when I talk about policies, I mean the whole gamut. There's the law, there are regulations, which are agency, federal and state agencies, how they implement a law, and policies sometimes are just the way things have always been done. And there's no law requiring those things to be in place. So examples might be requirements or hoops that people have to jump through just to get treatment or help, or to get housing or help. And so really taking a hard look at the whole gamut of these policies, laws, regulations, and ways things are operationalized, and removing the ones that are making it harder for people to live their life, get back on their feet, so to speak. And the other element, I think, is, and I'll just say diversion from the criminal legal system entirely. We don't need to use jail and prison as a way to deal with this issue. It doesn't work. It hasn't worked, and it's not working now. But we do need a robust system that can meet people where they are. If someone's ready for treatment, great. It needs to be available when they're ready. If someone's not ready for treatment, there are other types of services and supports that maybe can help them to reduce chaotic drug use or reduce the harms associated with chaotic drug use. So we really need to take a hard look at where we are right now. The other thing I'll say is funding. Not just more funding, but the right kind of funding. There's a large block grant, for example, that is given out to states every year for treatment, recovery, and prevention. And there's a proposal right now that 10% of that block grant go to recovery supports. Right now, most of that funding goes to treatment. Treatment is important. It's critical in many cases. But when you think about recovery as a lifelong process, treatment might just be a blip in someone's life. Or one element of what somebody needs to be successful here. So this 10% set aside proposal could really change the calculus. There are also ways for Medicaid and private insurance to step up and pay for some of these services. Some states have already begun doing this in their Medicaid programs, but there could be more incentives and support for those states to really encourage them to innovate. A couple more things, if I have a moment. You talked, Michelle, at the beginning about a peer support bill. Peer support is a really important tool. It's a good tool, but I think we have to really think about the workforce of recovery and peer support professionals, that an investment in that workforce needs to come with a recognition that this is a real industry, that people need good, livable, workable wages, good salaries and benefits, and upward mobility. If somebody is using their lived experience as a way of having their career, maybe they don't want to do that forever. Maybe they want to become a supervisor, a manager, an administrator, a government person. We have to make sure that people have a pathway, that this can be a real industry with real recognition, and that criminal backgrounds aren't a bar to employment in that space. A lot more to say, but I'll stop there.
I couldn't agree more. Jeff, do you have any reactions to this?
Well, I just wanted to say, when I heard Shelley say that we need to stop incarcerating people who are using these illegal drugs, of course, I couldn't agree more. Maybe a lot of our viewers are not aware, but just the day before yesterday, and this to me was big news, the Office of the United Nations High Commissioner for Human Rights issued a report saying that we should end over-reliance on punitive measures to address the drugs problem. And they called for not putting people in prisons or jails because they have a drug use problem. And we don't put people in prison when they have an alcohol addiction problem, or if they're driving themselves into debt because they have a gambling addiction problem. We don't put them in jail unless they can commit a crime. But somehow, if they use a drug that we don't approve of, we put them in jail.
Yeah, that's a great point. So just thinking about recovery as a long-term, lifelong process, what is it that clinicians then can do to better support addiction patients as they navigate that journey?
Well, I think that, well, first of all, clinicians have a lot to learn about this too. I mean, I haven't done a survey, but I would venture that at least half of clinicians don't have a good understanding of what addiction is, and they've pretty much absorbed much of the cultural myths that surround it. There are still doctors who think, for example, that treating addiction with methadone or buprenorphine is just substituting one addiction to one drug with addiction to another drug. And they think the only proper approach is abstinence, because they have this almost, they look at these drugs as evil, and they have almost a puritanical approach to it. So they need to learn. A lot of doctors just need to learn about this, and they need to change their attitude. These are people who have health problems, just like any of their other patients. But then again, as I said before, I think we're also, the clinicians are an untapped resource, because we're not allowing, which could be thousands of primary care clinicians, not just medical doctors, but nurse practitioners, physician assistants, to be engaged in treating people with opioid use disorder, by changing the laws right now surrounding how we do that, and also by changing the behavior of law enforcement towards clinicians who engage in that kind of practice.
Yeah, that's a really good point. So just thinking about how the rules kind of shift a little bit from state to federal. Shelley, you had mentioned that there's funding at the state level, there's funding at the federal level. I know, there's a lot going on with states and localities who are figuring out what to do with all these settlement funds, but with the approach to kind of helping clinicians through this process and help them serve patients as best as possible, what is the state and federal role in ensuring that addiction patients can actually go through recovery?
I keep doing it. A lot to say here. I think there really needs to be a recognition that housing is recovery, employment is recovery, taking care of your kids, that's recovery. And there are a lot of federal and state dollars outside of the traditional kind of treatment budget that can be used and aligned to support services that are needed. There's actually a great report that the Bipartisan Policy Center, and I know, Michelle, you were a part of this, published last year about aligning those funds at the federal level. And we published a report at the O'Neill Institute at Georgetown earlier this year about how states and local government can do the same and really start thinking about, what are we even buying with all of this money? And what is the what is even the goal? What do we want to see happen in 10 years, in 20 years, after all the settlement money is done? And I don't know that a lot of state and local entities are thinking about that, because we're just kind of putting out fires out there. I'll also say that even if, there was all the funding in the world, the way to access these funds for the organizations out there on the ground doing this work has to be changed. It's very difficult to access these funds. The application process, the grant making process, the reporting process are very multi-layered. They're difficult to navigate. There's federal grants, state grants, this agency, that agency. They're all different, all complex. One cost neutral thing that can be done right now is for this process to be made much easier and streamlined across the board.
That's great. Yes, I couldn't agree more. And I think the way we think about it at the Bipartisan Policy Center is really how to unsilo these barriers as much as possible and shore up as much money as possible. Jeff, I'll give you a last word, and then afterwards we'll switch over to our second panel. What can state and federal governments do to really ensure that addiction patients are able to go through recovery?
Well, as I've already mentioned, I think we need to reform federal and state laws, particularly with respect to treatment of using methadone to treat opioid use disorder. We need to have federal and state law enforcement reined in terms of the way they monitor clinicians who are treating opioid use disorder. And I would argue that both state laws and federal laws should say that if law enforcement thinks a clinician is practicing in an unusual way, but is not obviously committing a statutory crime, then that should be referred to the licensing board, because that's a standard of care issue. It's not a police matter. And then in the other areas that help recovery, we need to reform our zoning and land. This is local, the local zoning and land use restrictions. have stood in the way of a higher density housing, which is a major obstacle to increasing the ability for the homeless to get housing. It raises the prices of housing. So there's a lot of reforms that can be done on a state level in terms of land use and zoning reform, much of which is beyond my area of expertise, but I have colleagues at the Cato Institute who've written a lot about that.
That's great. Yeah. And I'll just say too that BPC has our housing policy group that's actively working on this too. And I know that they're very passionate about this. So more to come on recovery housing in particular. Just wanted to thank you both so much. Shelley, it's always great to share space with you and to hear about your personal journey. And Jeff, thank you so much for all of the work that you do. You're both doing amazing work, and thank you for elevating this issue as much as possible. So now we'll turn over to our next panel. I'm excited to speak with our two policy experts, Marielle Kress and Stuart Portman. They represent perspectives from both sides of the aisle and are actively involved in ongoing deliberations on the Hill regarding the SUPPORT Act. Marielle and Stuart both serve on the Senate Finance Committee, where they advise Chairman Wyden and Ranking Member Crapo, respectively, focusing on issues related to Medicaid, which is the biggest payer, and the Children's Health Insurance Program, or CHIP. Before assuming her position with the committee, Marielle also served with the executive director at the New York City Health and Hospitals. In this capacity, she oversaw the design, launch, and sustainability of the New York City CARE program, a healthcare access initiative that guarantees low-cost and no-cost services to New Yorkers who are ineligible for or unable to afford health insurance. Stuart has been advising on health policy for the Senate, including as a senior legislative assistant in the office of Senator Orrin Hatch of Utah. In this role, he was responsible for the senator's policies on Medicaid, Medicare, and pharmaceutical drug research and development, medical devices, health information technology, behavioral health, and others. Whew, it's a long list. Marielle and Stuart, thank you so much for being here. I know it's a very busy time in the Senate right now. And with the SUPPORT Act that you're both working to reauthorize, I just wanted to thank you because it's such a critical piece of legislation. So wanted to start by kicking things off with kind of the big elephant in the room, so to speak. I know there's a lot of chatter about a shutdown. How might something like that impact the ability for these programs to be reauthorized, continue to exist? What is going on? Tell us. I'll start with you, Stuart.
So thank you for having us here. I would say that it's while it is sucking up a lot of the air in most conversations, a lot of the work that Marielle and I get to do gets to continue behind the scenes. We know that discussions around spending are going to cause a lot of the broader debates to sort of rage on beyond what happens with a potential shutdown or not. But those conversations happen very much so at the leadership level, and especially for purposes of Marielle and I over in the House. So we get to advise and figure out what happens later on down the road, and whether or not there's other policies that can be a part of that conversation.
That's great. That's really great orientation. I know that some of the folks tuning in may or may not be as plugged in as you guys are. So that's really helpful. So just thinking about treatment for opioid use disorder and recovery, we know that both of these are possible, and yet we're still seeing, coverage of these issues kind of waver a little bit. So what is Congress doing to address Medicaid coverage of opioid use disorder medications and recovery services? And I'll start with you, Marielle.
Great, thanks. And I am really excited to be here. Thank you so much for having me. And I should just say that my remarks are off the record and not for attribution, and they represent my perspectives and not that of the committee or the chairman. So thank you for the question. I think there is so much still to do to support people experiencing substance use disorder and opioid use disorder, and also co-occurring mental health conditions that really accelerate the morbidity and mortality of people experiencing SUD. I was struck by the data that came out last week by the CDC showing that overdose deaths are actually at their highest levels in history. And so I think, it's clear that we really need to do more, and we need to do a lot of work in this space. But I wanted to talk a little bit about what the committee and Congress has done so far in the last couple of years. So last year, the Finance Committee held 2 hearings on youth mental health specifically, and we know that substance use disorder is disproportionately affecting young people and youth. And the Surgeon General testified about the state of the growing crisis and talked a lot about how there are significant gaps between the time that someone first experiences mental health and substance use disorder challenges and between the time they get treatment. So access to treatment is really critical here. And Senator Wyden is really committed to doing everything possible to help Americans get the care that they need. So last Congress, there was a great bipartisan effort to improve access to behavioral health care for families and create a set of policies in a bipartisan way in behavioral health that focused on, youth mental health, care coordination and integration, workforce challenges, telehealth, and parity. And a lot of that work came to fruition as part of the bipartisan gun package. And also at the end of the year, Omni last year. That was related to guidance to expand telehealth in this area, tools and resources for states to expand mental health at schools and SUD services, and then stronger enforcement of Medicaid's EPSDT benefit, which is really the gold standard of providing behavioral health services and all other services to children. In addition to also, justice related policies. I think we're not done yet. We have a lot more work to do. There are a lot of policies from this process that didn't get over the finish line. And there's a strong desire on the part of the chairman to continue the work. I can touch on some of the policies that we continue to talk about, like Stuart said, maybe a little bit more behind the scenes than what's happening in the press. But some of these touch on, requiring updated guidance from CMS to improve availability and the provision of mental health and SUD services through Medicaid for children and youth, and particularly for specific populations, because we know that kids, particularly in foster care and those experiencing other conditions also need additional support in this area. We want more integration models in Medicaid that meet people where they are in terms of receiving services. We're talking about the possibility of a demonstration and planning grants in the space of provider capacity for SUD providers in Medicaid. And I know we'll probably talk about that a little bit later. But we're really committed to getting real solutions across the finish line, particularly in a bipartisan way.
That's fantastic. And I think you're totally right. We'll touch on these a little bit more, but Stuart, wanted to turn it over to you to see, what's going on the Republican side of the Senate.
Yeah, no, appreciate that and would echo the broader disclaimers from Marielle. But I think that when we've had a lot of discussions and a lot of the focus last year, last Congress really was on youth mental health. We've had a lot of discussions on care within the community, how to expand resources, the broad expansion of certified community behavioral health clinics, so that over the course of the next, at this point, 9 years, every state that wants to opt into this model will have the ability to do so. And states are at different points in time and how they could develop that and what it means to offer 24/7 care. There's a lot of real world impacts that come from this, especially when we talk about our rural areas and some of the more geographically isolated areas where we have always had issues with properly resourcing care, especially behavioral health. So there is more to have, more conversations to have here. But I do think that there's also a discussion on a little further down the continuum of care as it relates to when people have more severe needs. And we know that the level of severity and acuity has been growing. We hear endlessly from hospitals, both children's hospitals and more general hospitals, about the inpatient boarding issues, emergency department boarding issues, the co-occurrence of whether or not it is a serious mental illness or a serious emotional disturbance, which are different terms for purposes of statutory use, which is why I would delineate them. But when we have those sorts of discussions, there obviously needs to be a discussion on making sure that people have an inpatient level of care when they need it. And I think that part of the discussion is also ongoing. And would any conversation would be incomplete without addressing the fact that states and providers have been asking for this for quite a while. It's probably the most bipartisan mental health issue at the state level. You could ask a Republican or Democrat state in terms of their Medicaid director, their governor's office, someone involved in sort of broader public health, and they would say lifting some of these restrictions on how they can provide care would do the most to help the most number of people. There's different settings than this used to be. You know, the way mental health coverage was provided in Medicaid back in 1965 is not the way coverage is provided today. And the role of the state, while essential, is not the only role when it comes to mental health today. So we need to evolve our payment models and not rely on what was drafted into the statute in 1965 as a standard when we're trying to make Medicaid the gold standard for all other forms of care.
That's great. Yeah. And we heard in our first panel just kind of the way that things like fentanyl are changing the game, the way that this crisis has evolved just even in the past few years. So that's a really good point. 1965 was quite a long time ago. So I'll just turn your attention, both of you. We're getting some questions from the audience around the Reentry Act, around what is being done in terms of having care become more available and expanding access to care in justice-involved communities. And I know you're both actively working on that in terms of the Support Act reauthorization, and that's something that Senate Finance is working on very closely. So Marielle, I'll start with you. What is Congress doing to address justice-involved communities?
Yeah, thank you so much for that question. And maybe before I go there, I'll kind of touch a little bit on Stuart's comments in terms of inpatient levels of care. I think, you know, the chairman has the goal of increasing timely access to appropriate care for people with SUD and OUD. But I think, you know, he is concerned, and we are concerned, that the conversation is often so focused on the IMD exclusion as the barrier to SUD and OUD treatment, to the exclusion of so many other state and federal policy choices that contribute to barriers in services. So, you know, I wanted to touch on that. There are so many different choices and options that states can take up in terms of, you know, the state plan rehabilitation option and the health home option, and so many other different levers that states do have. And, you know, and the focus on the reauthorization of this state plan amendment that is talked about in the reauthorization of the Support Act is, you know, often sort of taking up the air in the room and not letting us really focus on more of the continuum that we would like to see. And I think, you know, it's we're very much willing to talk about supporting access in inpatient level type settings, but we also really want to talk about investing in community services as well. And to your question about, justice involved individuals with behavioral health issues, I think that's a really important set of policies, maybe to pair with the other set of policies that we were just touching on. We know that the inmate exclusion in the statute imposes really significant barriers in access to care while people are incarcerated, and then also upon their release. I'm sure that previously in the previous panel, it was touched on that individuals re-entering society after incarceration, according to a recent journal article, are 129 times more likely to die of a drug overdose than the general population during the 2 weeks following their release. So I think, we are really focused on making progress in this area, providing services to folks through Medicaid prior to their release, care coordination, medication-assisted treatment, and other types of services, and making sure that people get access to care immediately when they're leaving incarceration as well.
That's great. Stuart, let's hear from you now about this.
Sure. So I would say when we're talking about some of these inmate-related discussions, we obviously have both a pre-conviction policy in the discussion related to sort of the due process bill that Senator Cassidy on our committee has led. And then we have the broader Reentry Act conversations on the other end. And I think a lot of our members are still looking for some additional clarity on the reentry side. We know there's a lot of state support, but I think there's some fair questions about how whether or not with the current 90-day allowable 1115 waivers, how that interplays with the need for a statutory change. There are some questions that I think we would need some answers from CMS on. We have some members that are very supportive. We have other members that I would say take a different approach. There's a lot of on the ground expertise shared by the criminal justice side of the equation. There's a lot of on the ground expertise shared from the Medicaid side of this discussion, and I think there's also a lot of injection of philosophy into a lot of this. We are talking about an expansion population. There are members of Congress that still have very strong views about Medicaid expansion. And there have been sort of proposals that could open up some doors if the goal was solely about access to care. But the longer that we have some of these broader philosophical debates around what is the appropriate FMAP for services, it makes it harder to see Congress coming to an agreement on ideas that are also quite expensive. And so when there's conversations related to what is, and we've heard all the arguments, and I think there are a lot of people that support these arguments as it relates to the importance of prevention, the importance of continuity of care. We've had discussions on whether or not there are ways to make sure that case management increases so that you have the ability to turn on care upon release. But while someone is still an inmate, there are just a lot of additional elements outside the criminal justice side that are much more ingrained in the Medicaid philosophical debates that take place here in Congress that I think have to be a part of any of these conversations. And I think especially to Marielle's point, the cost of these policies, I would argue, takes up a lot of the air of the conversation as well, because it is hard to see a focus on a lot of this that could occur when we have such limited Medicaid dollars, and we're talking about how those can best be used, and convincing a lot of the offices and members to put limited resources here as opposed to other areas has remained what I would refer to as sort of as a challenge. They see real world impacts in their states and their Medicaid programs on a lot of other areas. And so it becomes a prioritization question. So I know that is sort of a non-answer. We've had a lot of conversations. We have a lot of members with interest. We're talking about bipartisan bills, but we're also talking about trying to get things that can be broadly incorporated that folks would support. I think the reentry side has unique challenges given CMS's openness to sort of circumventing Congress in this regard. And I think that the due process element has challenges that, while there's immense support for it, that are related to the cost.
Sure. And I know, BPC is very looking forward very much so to continuing to partner with both of you on these things. We definitely understand the cost concerns and some of these access issues. So I'll wrap up with one last question. So in our first panel, we talked quite a bit about non-medical services such as recovery and supported housing, and how these can be a life-saving pathway for a lot of people who are recovering from addiction. In the past, BPC has recommended that states do leverage those Section 1115 waivers for Medicaid, so that the scope of these programs can broaden at the state level, and also that Congress broaden the scope of services that are covered under SAMHSA's formula grant programs. So the block grant, the state opioid response grant, et cetera. What is Medicaid's role in ensuring access to non-medical recovery services? And Stuart, I'll start with you.
Sure. I'll try to be brief. Noticing the time, but I'll say that I would say that there is a role, but how defined it is still something that's being figured out. Medicaid has a unique ability to impact broader social needs that other health programs don't have the same ability to do. And so there is a lot of conversation as it relates to food security, as it relates to what does it mean to be assisted through the housing process? What does it mean to have sort of a case management approach to a lot of the other social factors that affect someone's life, and have someone assist you through that? And I think there's a lot of support for that. And we've seen a lot of 1115s in a lot of states that have embraced that approach. Formalizing that outside of the waiver process into the statute, I think, is still an open question. And I think trying to make sure that Medicaid cannot be all things to everyone when you're dealing with defined budgets and a state share. And I think that trying to make sure that we do as much good as we can and help states have the flexibility to make those choices that are best for their populations, because they'll be different in every state. That I think is sort of the tantamount goal at the moment. But I think that we are anxious to read all the evaluations, because I think there is a reality that Medicaid will be more successful in some ways than others. And knowing how to best direct resources to the areas that are successful, I think, is the purpose of these 1115 waivers.
That's great. Mary, I'll give you the last word on this one.
Yeah, no, thank you so much. I agree with much of what Stuart mentioned, and the ability of Medicaid to experiment with providing services in this area, I think, is a real strength of the program. And I think, our members and the chairman are excited to see these initiatives in states. And like Shelley said in the previous panel, housing is recovery, food is recovery, taking care of your kids is recovery. So, all of these things are related to people's ability to stay healthy and succeed in their lives. And I'll just mention, Oregon's recent 1115 waiver proposal that expands health-related social needs coverage, food assistance, housing supports. And like Stuart said, I'm really excited and interested to see the evaluation come out, and sort of learnings from the process that's going on in Oregon. And then just kind of looking at additional proposals and guidance that might direct the various agencies and departments that deal with these issues, like CMS and HUD and other agencies and departments, to really try to work together to make sure that we are using our precious, federal and state dollars in the most efficient and effective ways. So I think that could be an area of interest on both sides of our aisle here. And I will just also say one last thing, which is None of these services are possible and none of this access is possible without coverage. And we're going through the most important coverage moment in the Medicaid program's history. And so we're really focused on making sure that states are able to keep folks who are eligible for the program enrolled in the program continuously moving forward. And I urge everyone to focus on that as well in their states and in their areas too.
That's a really great note to end on. I think we're all watching this very closely, and I thank you both for all of the work that you've been doing. I'll let you guys get back to your very, very busy schedules and, make sure that our country is on track. So thank you both so much. And thank you to Ken, to Shelley, to Jeff for all of your great remarks and contributions. On behalf of BPC and the BPC team, thank you for all the work you're doing. I saw some questions coming through from the audience for our first panelist and for our second panelist that we didn't get to, but I know that our folks here are very eager to connect with our viewers and talk through this more. So go find them on their socials, and that wraps up our event for today. Thank you very much for attending.